Good afternoon. Thank you all for coming in this postprandial moment. It's really an incredible pleasure to be at AMWA. I have exactly 30 minutes, so I have to keep everything really short. So I will just say my thank you to all of you. I think that AMWA is especially important during these times. I'm going to talk about clinical empathy today. I'm trying to give myself, can you all hear me? Is that good? Okay, thanks. I'm going to make two major overarching points. The first one I'm going to make with a few slides, but I have a feeling now it's familiar to people, but it wasn't 20, 30 years ago when I started working on empathy, which is that the same day-to-day empathy you feel for your friends, when you're the emotional responsiveness that you have to other people's situations is an essential part of effective medical care. When I was starting, everyone said that doctors had to be detached to be effective healers. And we now have a huge body of empirical research showing that you're much more effective as a physician if you're genuinely empathic with your patients, just as you would be with other people, real emotional empathy. So I'm going to start with that for a few minutes, and then I'm going to get into the real question, which we all have as physicians, which is what happens when that emotional involvement makes things confusing, difficult, overwhelming? How do we handle the challenges of emotional engagement with people suffering? And for that, I'm going to argue that the most important thing is to stay empathic, but to cultivate curiosity about what your emotions are showing you about the patient's situation, and to become expert at using your own emotions as cues and clues to be more curious about your patients. Please come sit up front. I want to be able to see everybody's faces. So that's the two things I'm going to cover. So first a few slides, then I'm going to tell you about a very painful case I was involved in early in my career, and then we'll talk about how to handle it. First of all, as I said, when I started out, the word was that doctors had to be totally emotionally detached. And that didn't seem right to me, but there was no research showing otherwise. But what we now know is, oh, here's my disclosure, none. It's not a big money-making field, empathy. Okay, I'm joking. Empathy, we used to think that you need to be detached to make an objective diagnosis. But as you all know, the heart of diagnosis is getting a full history. And we now have studies that have been replicated around the world showing that when you're non-verbally emotionally attuned to your patients, you'll get a more thorough history. And they do these studies by wiring up like a primary care clinic for a year, so everybody becomes used to the fact that they're being recorded. And then they look at the doctor-patient interactions, and what's so amazing is, if you've ever seen the infant, usually mother-infant studies, where the infant and the mother's nonverbal emotional attunement is beautifully aligned, in doctors that are empathic, that same thing's happening with their patient. And when you have that nonverbal attunement, patients reveal much more information. So that's incredibly important. You'll get a fuller history if you're actually empathic. First part of effective medicine, get a good history. Second part of effective medicine, adherence to treatment. 50% of prescriptions are not taken as prescribed. People don't tell side effects. They don't know what to do. They don't understand what they're supposed to do. They don't agree with it. None of that gets communicated, so they just don't take the meds. The biggest way to make medicine that we're already paying for more effective is to have more adherence to treatment. The biggest predictor of adherence is trust in your physician. The biggest predictor of trust is that the patient perceives that the doctor is genuinely worrying about them when discussing a worrisome matter. Not friendliness, not anything else, but the perception that there's real worry there. So that's effective treatment. Third really important part of healthcare is giving bad news and helping people get activated and be agential when they have a new cancer diagnosis or another serious diagnosis. And we have good long-standing research. I'm giving you the original classic studies, but these have all been replicated many times. When bad news is delivered in an empathic manner, when the patient perceives that the doctor is empathic, there's decreased patient anxiety, improved coping skills, and more likelihood that the patient will be able to take steps to make treatment decisions, get support groups, and all of that. So that's pretty much all I'm going to show you slides-wise. Let's see, are we closed? Okay, this is now a humanities talk. I'm just going to talk to you. I'm not going to show you any more slides. This all sounds great, right? And there's a lot more we could say about it if we had longer time. But what we all know is, even if empathy is really valuable, if we're emotionally responsive, and we're dealing with such sad and challenging situations, we need another skill. We need a professional level of empathy skill, and that's where being really curious and really interested in what your emotions are and what they're telling you about the patient is so important. So I'm going to share a very upsetting case to you that happened early in my training, and in one way or another, in a way, my whole career has been about this case. A medical surgical team at a major hospital requested a psychiatry consult for Ms. G, a 56-year-old woman with diabetes who had just had her second above-the-knee amputation. She had a long history of renal failure, was not a candidate for a transplant, and required dialysis 3 times a week. She had come into the hospital willingly for the surgery, but now she was refusing dialysis, even though that she would die without it in a matter of days. She was refusing to tell the medical team why, and they wanted both a psychiatrist and an ethicist to evaluate her decision-making capacity. As a trainee on the psychiatry service, I was sent in first to see the patient and report back. I walked into Ms. G's hospital room and was shocked to see a child-sized bony woman curled up under the covers, her eyes closed, her head shrouded, and her back to the world. She was in obvious pain, with her face tensed and her mouth wide open as if to scream, reminding me of Munch's painting, The Scream. My first instinct was to run to her medical team and say, give her more morphine, but I remembered that one reason that the medicine team had called for psychiatry was that no safe amount of pain medication seemed to touch Ms. G's pain. After introducing myself, I invited her to participate in a guided imagery, which I had learned to do with cancer patients in extreme pain who found answering questions too difficult. I spoke of imagining herself in a more relaxing place, the beach, seeing and hearing the ocean, feeling the sand and the soft breeze on her skin. Her face spontaneously relaxed, she kept her eyes shut, and gradually her breathing normalized, and she seemed briefly to go to sleep. I returned a few hours later and found a group of Ms. G's women friends holding a vigil outside her hospital, anxiously outside her door. After telling me how worried they were about her, one of them said to me, ask her about her husband, that creep. Going back into her room, I saw that she was again in terrible agony. I repeated the guided imagery, and again she relaxed and seemed much more comfortable. I waited for several minutes and saw that she wasn't asleep. Knowing that time was of the essence and that I needed to learn something about her state of mind, I said, is there anything besides your body that's hurting you? Her eyes shut, she began to speak to me for the first time. Yes, but I don't want to talk about it, she murmured. I just want to go to sleep. I waited silently to see if she would say more. After a long pause, she said very quietly, my husband doesn't love me anymore. He told me he's in love with someone else. He wants to move in with her while I'm in the hospital. He said that with my amputations and all my medical problems, he could never be attracted to me. And she started to cry. Listening to her story, I was deeply moved and imagined facing a future in which I was literally cut off at the knees, abandoned by my spouse with no legs to stand on. But before I could say anything, Ms. G turned to me and looked me in the eyes for the first time. And she looked furious. I felt afraid that she would somehow try to move around too much and hurt herself or throw something. She screamed out, why the hell did you ask me to talk about this? I told you I didn't want to talk. I just wanted to be left in peace, to sleep and never wake up. Making me think about what he said is the cruelest thing that anyone has ever done to me. Don't ask me any more questions. Get out of here, get out of here. And she kept shouting, and I left the room. Ms. G was refusing treatment and would die rather than think about her husband's rejecting words. Feeling hopeless, I went to talk to her other doctors and the ethicist on the case. The ethicist urged me to be rational about Ms. G's situation. She met the legal criteria for decision-making capacity. She knew the risks and benefits of treatment and non-treatment and gave reasons to support her choice. She had told him and her surgeon that she knew she would die without dialysis, but that her future as a double amputee with further complications of her diabetes was one that she no longer wanted. He then looked at me and said, "Look, you can't take her home with you, so leave her alone." I then went to meet with her longstanding internist, Dr. L., a man with a reputation for caring about his patients. Doesn't all this talk about respecting her right to die seem inadequate, given how abandoned she must feel? I asked. Yes, he nodded and sighed with resignation. But think about it humanely. What kind of life does she face now? Wouldn't you want to die if you had lost your spouse, your legs, your kidneys, and faced a future of blindness and other medical problems? Let's not ask her any more questions. Let's just make her as comfortable as possible and accept her decision to die. As a trainee, I needed to consult the supervising psychiatrist about my approach to this case. I discussed the fact that only 2 years before, after her first above-the-knee amputation, Ms. G had also become very depressed and hopeless, yet with psychiatric treatment had recovered her optimism and energy. She had gone on to enjoy her work as an artist and continue her active social life. Her doctor's notes from just a few days before this admission, in fact, had supported this surgery, implying that she had years of reasonable health and functioning ahead. She wasn't blind at this time. She didn't have those complications of her diabetes yet. It seemed likely that what was happening is that she was in acute reactive state from the terrible way her husband had just rejected her, and this was severely restricting her present view of the future. The senior psychiatrist agreed that this was all probably true, but said that we could do little for Ms. G because of the ethical obligation to respect her decisions. He pointed out to me that she was adamantly refusing psychiatric treatment as well as dialysis. He said, "Look, the decision is hers. There's no evidence that she's cognitively impaired, as can happen if you skip dialysis, for too long. There's no mental illness making it impossible for her to decide, even though she's very upset." And then he looked me in the eyes and said, "Anyway, if we set aside our own emotional reactions, looking at me, especially our wishes to rescue, isn't it just true that she faces a terrible future? We need to leave this woman to die in peace and guard against imposing our own wishes on her." A conference was held with the surgeon, the internist, the psychiatrist, and the consulting ethicist, all white, able-bodied men. She was given this news as well as more pain medication. She became lethargic but comfortable for the first time since hearing that her husband was leaving her, and she died that evening, never again speaking the painful words that her husband had said to her. What mistake did we make in this case? First of all, some of you may be thinking about the decision capacity issue, and I've written about that in this case elsewhere, but by the criteria that she technically met the criteria. So I don't want to get into a debate about that. That's another interesting question. But she met what most people would consider the criteria at this point. What I see as the biggest ethical problem in this case was a failure of professionalism. We were not aware of our own emotional reactions and how much they were skewing our prognosis of her future. We didn't realize that our predictions that several of the doctors made, that she had nothing to live for, that we thought those were facts, but they were actually expressions of our own emotional reactions to her that we were unaware of. First of all, while we were all clearly very affected by her hopelessness, we didn't realize that. And this was very notable. As I mentioned, the notes in the charts had just said a few days ago that she was a very reasonable candidate for surgery, that she had, reasonably good quality of life and health ahead. And we made this sudden 180-degree turn without even noticing it. It's true that the big change was now she had lost her husband, but she was not the kind of person who only was living for her marriage. She had a very active life as an artist, which was not threatened by her diabetes. She had a very active social life, and she had a history of getting over very serious personal losses by working through those losses, by receiving, even if she was refusing psychiatric treatment this day, she'd ultimately worked with psychiatrists and done very well in the past. It was only right now, in the immediate aftermath of her husband's cruel, rejecting words, he'd literally said them the day before she died, that she felt catastrophic about her future. And we just took up her catastrophic feelings unthinkingly. And this is what happens when we resonate emotionally with other people, is their emotions cause us, without even realizing it, to feel similarly. And we, if we're not aware of our emotional resonance, start to believe those feelings are indicators of facts. We not only didn't think about how hopeless we were feeling as we resonated with her hopelessness, we also weren't aware about how helpless we were feeling. She was kicking us out of her room. She was refusing all care. She told me that I had done the worst thing ever. She kicked me out of her room. When we feel helpless as doctors, that's usually when we act out. We don't know what to do, and we try to get rid of the patient, the problem, whatever, as soon as possible. We were not aware of how helpless we were feeling. And the most important thing about this case is that what was happening inside Ms. G were very complicated emotions. We saw them as way too simple. We just saw her as a woman in despair who no longer wanted to live, when really that was the tip of the iceberg. She had just gotten the bad news. She was subject to all kinds of emotions, and they were coming out not from what she was saying, but how we were feeling. What I want to show you, well, I hope this case shows you, is that just as children show their emotions in their play. When you do play therapy with a child, you have them basically use dolls and other things to act out their feelings. But as adults, we never stop acting out our feelings. We just use other people the way children use toys. In the hospital, every time there's an emotionally distressed patient, the likelihood is the whole medical team is acting out that patient's specific emotional configuration. And yet we get very little training to realize that we are acting out patients' emotional dramas. And this can lead to tragic outcomes like turning up the morphine too quickly. So in retrospect, what could we have done differently? We could have been educated to have a lifelong practice of being curious about what our emotions are telling us. What are we feeling and what are they telling us about a case? For example, what I now realize is that Ms. G's desire to die immediately, she wanted to die immediately. I've seen that as a psychiatrist now over and over. When patients are immediately, acutely suicidal, it's usually not from despair, but immediate shame and rage. And she was most likely, I believe, enraged and ashamed with the way her husband had brutally abandoned her. That kind of feeling is something that's very hard to tolerate even for another day. And what I've seen when working with suicidal patients is if you can recognize the shame and rage and acknowledge it, often they're really relieved because there's another part of them that wants to live, and yet they couldn't tolerate the thought of even getting into that because of the overwhelming rage and shame. We missed all of that because we weren't curious. We didn't realize that every person is emotionally complex, and we're never all in one state of mind. So even when people seem very hopeless, there's always ambivalence under the hope, and usually shame and rage are what masks that. Thus, my recommendation from this case is that what we needed most was not to stop being emotionally reactive, because we wouldn't have known enough about what was happening with her if we weren't emotionally reactive, but rather than feeling despair and helpless around her and then agreeing she had nothing to live for and turning up the morphine because we didn't realize we were feeling helpless and despairing. We needed to realize how we were feeling and then be curious about what it could teach us about her situation. We needed to be aware and curious. So I hope this makes that point strongly, but now since you're all super busy, I want to give you 4 tips about how you can do that given how busy you already are without increasing your workload and making empathy just another overwhelming task for your medical practice. I think these 4 things are actually kind of surprising. The first is, if you're having trouble being curious about the patient's perspective during a conflict, when someone doesn't want care or there's a family conflict where people aren't taking care of some family member and you're feeling really upset about how the patient or family are acting and you're not curious about why they're acting that way, don't feel guilty. Recognize that the biggest reason a lot of people don't feel curious in those situations is because they care a lot about patients and outcomes. So Very caring people, basically the closer we are to someone, the harder it can be to be interested in their perspective during a conflict. And this should be something you all realize if you've ever had a relationship or in your life of any sort. Personal relationships, love relationships, parenting relationships, being the child of parents, all of those things, if you think about it, when somebody you really care about is doing something you think is really bad for them, you can lose your curiosity about why they're doing it. So the first thing I want you to do is not feel bad if you haven't been that curious, because it may just be that you're just trying to get people as well as you can under all kinds of extenuating circumstances. So we have to actually take an extra moment, take a breath, and think to be curious. And speaking of taking a breath, the second surprising thing is that rather than ignoring, as students and interns, residents, and physicians in practice, rather than ignoring our anxiety and distress when we feel it, paying more attention to it in a certain way can help decrease it. And you heard mindfulness mentioned this morning. We just actually there was a huge study in Germany that I was a consultant for that showed that certain kinds of mindfulness help and certain kinds don't. So I think a lot of what's being marketed around the country is not really the most effective thing, but I think that what's really important to know is you don't need an expensive, intensive mindfulness training. What you need is to literally give yourself the time to take a breath. Give yourself the time to feel your feet on the floor, or your seat, we call it your sit bones in the chair. It's interoceptive awareness. Where's your body? Where's your breathing? And sort of embrace your anxiety. Recognize that you will be anxious because you care. And that anxiety, doctors who are not anxious ever are sociopaths. Seriously. Don't feel bad, and especially feminist issue, women are always blamed for being anxious. Embrace your anxiety as a sign of caring and be more aware of it while you're feeling it. And you'll be amazed how much, there've been a lot of studies now showing that just taking a breath, counting to 10, especially if you're angry, walking out of the room for a minute or two, can really improve the communication, and actually it's been looked at to lead to better clinical care and outcomes. A third important and surprising observation is that you don't have to be a psychiatrist to do any of this. In fact, I am a psychiatrist. Being one can be kind of an occupational hazard, because when people are really upset, when you're upset and the patient and the family are upset, the worst thing you can do is say something like, about the person's mother or something. They don't want you to interpret them and tell them something psychologically knowing. They want you to listen very closely to their exact message, and if you can repeat their exact words back, you will be more effective than if you do anything else. So in one situation, I was very anxious. A man had Guillain-Barré syndrome, which is causes a sudden paralysis. And some people get better, some don't, so it's very uncertain. And he was in the ICU, paralyzed from the neck down, and he had been a very powerful business leader, and he was a patriarch with his wife and 3 adult daughters, all sort of catering to him. And he was enraged that he was in this position, and so he started refusing care in the ICU and wouldn't let the nurses do anything, and they called in psychiatry. And I went to meet with him, and he essentially yelled at me about how useless psychiatry was, how useless the nurses were, what a waste everybody in this hospital was. And I felt intimidated, but I'd learned from the other case not to run out of the room, so that option was gone. So I basically just I couldn't think really, so I just said his exact words back to him. I said, everything we're doing is useless, a waste. And that was it. He just felt heard and connected with me and started working with me, and it really helped turn that case around. And in fact, what he started to tell me then was the story about his situation, how he saw it, his story. We know now that if we just let patients talk at the beginning of a clinical meeting, of an interview, if we don't interrupt them, they talk on average for only about 45 to 60 seconds. So we have to learn not to interrupt them at 18 seconds, which is what we do. We can give them that minute to tell their story, and that will make a huge difference in the outcome of the session. That's been studied. But one of the things about patients telling us their story is that it helps us decrease our anxiety. when you think about when you go home at night after a hard day at work, how do you relax? Basically, other than having a glass of wine, the only way I know that, and well, exercise, I guess, but, you know, not at night, it's hard for me. It's a good idea, it's better than wine, but I don't know, some of each. But the way most people relax is by engaging in listening to other people's stories. You turn on a TV series or watch a movie or read a novel. Patients telling us their stories can decrease our anxiety just as well. So that's another way to regulate your emotions while you stay empathic. Finally, my fourth tip is when a patient starts yelling at you and is angry at you and blaming you, and or you're angry at them, that is a huge opportunity. We heard this morning from the health leaders that the moments where things are going terribly are actually their best opportunities for impact. And that's really true in clinical care, too. I'm going to let the next Jodi in a minute tell you something about that she has to share, about the value of anger. But people getting angry at each other does not mean you've blown the case. It doesn't mean you're a bad doctor. It means that the person, anger is the tip of the iceberg of fear and grief and other emotions that patients need to share with us. And patients don't just come in and tell us their most difficult and complicated emotions. The way that patients share their emotions with us is by making us feel them with them. They inscribe their emotions in our embodied states. If we lose empathy, we lose all that information and we're much less effective. If we let them move us, we get all that messaging, but then we have to manage it, and I've hopefully given you some ways to do that. But if we can tolerate those very difficult situations and not run out of the room, I think we can make an enormous difference. Thank you.